and safe as can be expected during the current times. I know we're seeing cases go up here and there's a bit of trepidation with the future, so I hope you're all well, and appreciate the chance to talk to you for the next 45 minutes or so and give a whirlwind tour on this landscape of ethics education in short-term global health, past, present, and future, where I hope the future part really stimulates some good discussion and Q&A for what we need to be doing to do this better in the future. So just a couple disclosures, no real active conflicts. I did receive an honorarium for this particular position paper, the American College of Physicians, and I've also had my global health work funded by ELRA's Research for Health and Humanitarian Crises, or R2HC program. So what I really hope is that by the end of today, you'll be able to explain what I described as the shift from thinking about short-term global health activities from one of altruism to one of social justice. I hope you'll be able to appraise the current state of the evidence base regarding ethics education for short-term global health programs and describe at least two, probably more, research needs for ethics education in short-term global health. And I want to start by giving us a sense of this bigger picture question of what is short-term global health? Well, sometimes short-term global health training activities actually find themselves in the popular press and not always for the right reasons. Let me give you a couple examples of stories like this one. An American with no medical training who ran a center for malnourished Ugandan kids and is accused of contributing to the deaths of more than 100, partly by exceeding her scope of training. We'll talk about that issue some. An article in the Scientific American blog, which describes the trouble with medical voluntourism. And lastly, this article, hashtag Instagramming Africa, the narcissism of global voluntourism, where the article quotes from The Onion and jokingly cites that a visit to an African village can completely change a woman's Facebook profile. So clearly a critiques here of the notion of voluntourism, and I think asking the question, who really benefits from short-term global health activities? How significant are short-term global health activities as far as a bigger picture? And we don't really have great estimates, partly because of the disseminated and unregulated nature of many global health activities. But I think most people believe that short-term global health activities are completed by hundreds of thousands, if not millions, of volunteers annually. That they likely involve hundreds of millions or even up to several billion US dollars each year. Typically include research and or service activities, both clinical and non-clinical alike, public health, education, often involved in these programs. They tend to range in duration from a few weeks to a few months. We'll talk about that some. And they really are a global phenomenon. For example, if we go across the pond to the UK, we see that 40% of medical students in the United Kingdom participate in global health activities. So this really is a major enterprise, and I think it underscores the importance of thinking about the ethics challenges that come up in short-term global health. Now, you may be wondering a little bit about US medical students. What does the US context look like? And in fact, the AAMC does collect data on this topic. And after we saw a rise in global health experiences among medical students, the past few years have actually seen a slight decline in the percentage of students who have gone abroad during medical school. So here's a question from the medical school graduation questionnaire. It asks about global health experiences, and you can see, looking from 2015, around 30%, and that 30% followed a rise, I should say, over the preceding decade. We've now seen a slight decline, down to the 2019 data, around 24%. Now, the reasons for this decline really are unclear. We expect to see it a little more, of course, because of COVID, less travel going on. But I'd still like to point out that almost 1 in 4 medical students is still a pretty large number of students going abroad. Again, making it really important that we think about ethics in short-term global health. You may still be asking, what is short-term global health? And I think if we start to unpack a couple of these terms, we can actually foreshadow some of the future challenges that I see in education and research on education in short-term global health activities. What really counts as short-term? There's no standard definition of short term. It's kind of relative. And in fact, when we've done surveys of our own ethics curriculum, ethicsandglobalhealth.org, we find that people tend to think that short term is whatever is shorter than what I've done. So if you've been abroad for 3 months, then a month is short term. If you've been abroad for a year, then 6 months is short term. So there's an interesting finding about the relative nature of short term. Global is also a tricky concept to define. We often hear that local is global, and that's true, but it complicates how we think about what counts as a global health activity. And in fact, the short-term global health ethics literature is often critiqued for not being attentive enough to the idea that many of the concepts we describe are equally applicable in underserved areas, maybe in our own backyards. And finally, of course, health, tricky to define. We hear about health and all, again, another important mantra, but what really counts as a health activity abroad? Is it healthcare delivery? Is it research? Is it public health? Is it education, and so on? So some of these challenges, I think, in defining short-term global health will complicate how we imagine evaluating ethics education and short-term global health more generally. So that's a little bit of a summary of what the big picture of short-term global health is. Now I want to move to talk about how we got to where we are today, at least as far as ethics education comes regarding short-term global health activities. I would summarize this historical transition with this figure and posit that there is potentially moral progress that we've made from a sense of altruism to thinking of these activities to the lens of justice. So we might start by thinking of global health activities abroad as being altruistic. That is, it's giving something away at cost to oneself, where the cost to oneself part of this is really important. It's supposed to actually come at a sacrifice or a cost to one's own person. But then I think we realize, wait a minute, individuals who go abroad seem to benefit in myriad ways: cultural awareness, education, experience, and so on. So then we might come to think of these activities as one of charity. That's the idea of giving something away. In ethics terms, it's supererogation, that is, something that is praiseworthy to do, but not necessarily required. But then I think we started to learn, wait a minute, sometimes when individuals go abroad, they can actually cause harm. If they can cause harm, we should think about these activities differently and perhaps through the lens of justice, that is, giving to others what they are due as human beings. Now, if there has been this shift, it's really important in ethics terms because we tend to hold obligations of justice to a higher standard than we do obligations of charity or altruism. In other words, we tend to have more discretion about what we do when it comes to charity compared to obligations that come through the ethics lens of justice. And I think we'll see that as I describe a bit more of the history. So in the early 1990s into the early 2000s, I would describe this recent history as being one of recognizing ethics, especially recognizing the potential for unintended harms. So in this period, we started to see publications in mainstream journals like JAMA describing anecdotal case reports of duffel bag medicine. New England Journal, volunteering overseas, lessons from the surgical brigades. My own work in the Hastings Center report. An article in Health Affairs describing the experience of a medical resident adrift in Africa. So these anecdotes and case stories, I think, started to raise awareness and question the idea of who benefits from short-term global health programs. And I think this quote you see on the lower left really illustrates this concept well. This is from the New England piece. There's a profound need in this community, but right now, the vast amount of donated time, energy, and money does more to stoke the egos of the Americans sojourning here. And this was an important recognition, recognizing the potential for unintended harms and raising the awareness of ethics issues in global health training. Now, following on this in the 2010s, the academic community actually responded by creating ethics guidance. If you go back to those case stories, many of them, including mine, pointed out the issues and then said, look, we need guidance. We need to have ethics guidance for how to manage these issues when people go abroad. And in fact, the academic community responded. Here's an early article called Global Health Ethics for Students. We'll talk a little more about it later. What's probably the most widely known guidelines and best practice guidelines are the WAIT guidelines here from the Working Group on Ethics Guidelines for Global Health Training, published around 2010. And then more recently, this position paper that I was involved in from the American College of Physicians. So the 2010 saw this creation of ethics guidance, filling the gap that had been identified in those early case reports. Now, actually, by the late 2010s, you might say, well, now we've got too much of a good thing. So in a review of, believe it or not, 27 published ethics guidelines, this is a meta review that tries to distill down from all the guidelines, what are the core principles that seem to be in common among all of them. You can see here, appropriate recruitment, preparation and supervision, a host partner that defines the program, including the needs to be addressed, sustainability and continuity, respect for governance and legal and ethical standards, and regular evaluation of program impact. So I think we see in this meta view of the ethics guidelines a bit of that transition from thinking of these activities as altruistic to justice, because the demands that are placed on programs here, I think, are far higher than we would ordinarily require of something that's merely charity or merely altruism. So I think evidence of that shift from altruism toward justice. Here's another way of looking at what I described as the meteoric rise of interest in short-term global health. This is a graph that simply shows you citations by year under the medical subject heading of medical missions. You can see that there's a little blip around the 1970s, increase again in the 1990s, which we attribute largely to the HIV/AIDS epidemic, followed by another exponential rise really after 2010. So a lot of interest in this particular topic. Now, within this history, those of you who have been involved in global health probably know there's been a parallel thread, which is a lot of attention to research ethics, largely motivated by placebo-controlled clinical trials conducted in sub-Saharan Africa related to HIV prevention and prevention of transmission. Within this parallel thread of research ethics, there were major reports that came out from the Nuffield Council in the UK, the National Bioethics Advisory Commission, presidential level commission here in the US, and revisions to the World Medical Association Declaration of Helsinki. So there's this actual parallel thread going on at this same time about research ethics and the ethics of research in developing countries. And these two literatures, ethics of research and ethics of care, seem not really to talk to each other, right? So we describe a problematic bifurcation in the way we think about ethics, that there's on the one hand, ethics of research, multiple international guidelines, and so on, and then this separate conversation about the ethics of care, resulting in the WAIT guidelines, the Global Health Ethics for Students paper, the guidelines I contributed to, and so on. Now, we actually think that this bifurcation is somewhat problematic, that separating the way we think about ethics in this way causes problems for the way we think about ethics in general. And there are at least three reasons for this. One is that the ethics principles, which I'll talk about a bit in a moment, that we tend to use in each context are actually pretty similar, right? We talk about respect for persons and choice. We talk about beneficence, weighing the benefits and risks to well-being. We talk about justice, both in terms of distributing benefits and burdens fairly, as well as justice and fair decision processes that are transparent, inclusive, and so on. So we do tend to use the same ethics concepts. I think more importantly, what we've seen is that the experience of individuals abroad supports the idea that these issues actually overlap in the real world. We've collected data I won't show you in the Fogarty program that I think illustrates this well from focus groups and interviews. And I think this is especially true if we take a step back and think about those meta-level guidelines, where guideline 5 was regular evaluation of program impact. And once we start to require evaluation of programs in the real world, you can see that research and service are going to get closer together, because now we're saying as a matter of service, you're obliged to conduct some level of research to see what the impact of your program is in the real world. I think the third problem is that I think keeping these separate runs the risk of short-circuiting moral reasoning. That is, we may start to think of things as merely being an IRB issue because we're in that research ethics paradigm. And if our IRB application says nothing about post-trial obligations for what to provide participants and so on, well, then we're sort of off the hook. So I think we could actually benefit from bringing some of these concepts together. Now, as we move forward towards the future, I don't want us to forget the big picture. I don't want us to forget that I think we've actually made moral progress, even if we have a long way to go. I don't want us to forget that there is a past, which I've not described and would be happy to in the Q&A, a historical shadow that's cast by the way short-term global health activities were conducted all the way back into the 19th century. This is Albert Schweitzer, very well known for building a hospital in Gabon, but also sometimes criticized for racist undertones in parts of his writings. And that historical shadow is, of course, cast upon all of us who are active in global health today, whether we know it or realize it or not, these histories of structural inequalities, colonialism, and so on. We need to keep in mind this history that has long recognized ethics issues and the possibility of unintended harms. We also have to keep in mind that as we enter global health, we necessarily enter an environment where healthcare is a human right and human rights in general are often described an important part of the global health context. And also the reality that sometimes when we're doing work in global health, the reality is that we just need to address ethics issues from a practical standpoint as a matter of finding a way to get things done. So that's a little bit of the past. I think how we got to where we are today. And now let's talk a little bit about that present. Where are we in terms of education and ethics education for global health activities? Well, fortunately, in a landmark moment a few years ago, the World Medical Association made a statement related to ethics considerations in global medical electives and reinforced the idea that preparatory training, including training in ethics, is itself an obligation. So we now have, I think, widespread recognition of the need for pre-departure training, and in particular, pre-departure training that includes attention to ethics. So another landmark moment, I think really important sign of progress to see these issues elevated on the global stage. And there are now plenty of ethics education resources out there. I'm going to show you a couple slides that have just a few of them. So the top left is the introductory curriculum we created when I was at Hopkins with colleagues at Stanford, funded by the Doris Duke Charitable Foundation. The lower right is Boston University's program. Here's another smattering of more. University of Minnesota, Ethics of International Service Learning from University of British Columbia in Canada, the Global Health Education Consortium, Child Family Health International. So you can see there are plenty of curricula out there and education resources out there for people who want to prepare their trainees, residents, medical students, fellows, or really anyone who hasn't been abroad before to prepare them for the ethics issues that might arise when they're going abroad. I want to talk a little bit about what the evidence base is behind some of these programs and I think lead us into where we need to go in the future. So there has been a systematic review of ethics training resources. This review found that most, 8 of them, used case-based learning methodologies. Others were actually just guidelines. Not really sure that counts as a methodology, but they were guidelines. This review found that there was no evaluation of these resources above level 3 evidence, that is non-randomized case series studies. I think that's probably itself even a bit of a generous evaluation. And they found that the ethics emphasis within the curricula were on the following themes. Themes around beneficence, such as exceeding level of training or exceeding one's scope. Respect, avoiding posting of photographs online. Local culture, issues of inappropriate dress. And of course, issues of justice, such as how to manage donated resources. And we did our own systematic qualitative synthesis to further inform the literature. And what we were looking for was actually primary research studies examining what trainees actually experience when they're abroad. And this we think is really important, right? If we're going to tailor ethics education to experiences abroad, it needs to be informed by what trainees actually report having experienced while they're abroad. We only found 14 studies. All of them were published since 2010. In total, less than 200 total medical trainees were represented in this literature. There's an asterisk there because I think that's already changing, but as you can imagine, thinking back to that hundreds of thousands, if not millions of people who go abroad each year, to have an ethics literature framed around only around 200 is pretty minimal. We also found that while many ethics themes were well represented and consistent with some of those existing training resources, others were not. Sustainability was a concern we didn't find well represented. Issues of moral distress, frequently reported by trainees abroad, that is, knowing the right thing to do, but being unable to do it because of internal or external constraints, frequently reported by students, often not part of education curricula for preparation. And a third issue, managing social hierarchies abroad. The challenge that trainees sometimes experience when they go abroad, they find themselves in a situation where they don't understand the social hierarchy. They get caught in the middle. And in fact, that can contribute to all sorts of other ethics issues, right? That's how exceeding scope of training occurs. That's how unintentional harm occurs, and so on. So another theme that it seems that trainees are reporting, it doesn't seem that it's included in a lot of the ethics education curricula that we've seen. Now, I want to show you at least 3 examples of evaluations of ethics education, because these are on the rise and I think do represent the future in a really important way. The first one is the Wisconsin Sugar Program. This is the simulation use for global away rotations or sugar program. Educators developed 8 paper-based simulations that were used in 2 half-day sessions, and they evaluated its use within 51 residents. These residents found the simulations useful. They believed the simulations would change their preparation plans. And they reported experiencing significant emotions around the particular simulations. This program itself was framed around 4 core emotions, or 4 Fs: frustration, floundering, futility, and failure. And in fact, they found that the simulations seemed to elicit those kinds of emotions within the residents who took part. Second example comes from UCSF. They followed a modified Kern methodology and then developed simulation training, which in this case were 10-minute cases involving actors in 4 different areas: scope of practice, responding to corruption, respecting privacy in the context of HIV, and informed consent. Evaluation involved 53 participants in 2013 and 14 who believed the simulations were effective at highlighting ethics dilemmas, were useful, and made them more aware of ethics. And they reported that the simulation training was likely more effective than other approaches. They perceived that the scenarios did not necessarily teach right or wrong, but at least taught them a way of thinking through ethics and short-term global health issues, and so on. Third example in this rapid-fire review, this comes from Yale, Tracy Rabin's group. In a pre-post evaluation of a 90-minute case-based ethics workshop that involved 82 medical students who undertook electives at 16 international sites from 2012 to 15, they found that this case-based workshop improved self-reported outcomes such as sense of preparedness, ability to define ethics, find someone they could contact if they needed help, and so on. 65% after they returned from their international site reported that they did actually experience an ethics dilemma abroad. Now, many of us in ethics think, wow, this should probably be higher than 65%. Ethics seems to come up all the time in global health activities. Why isn't it higher? But after the ethics training, students did at least feel that they were primed to recognize ethics dilemmas when they eventually went abroad to their international site. So I've given you 3 examples of ethics training and its evaluation. And I talk about the general themes that I think we can take from these examples in just a moment. But before I get there, I want to give a little bit of a cautionary tale as a bit of a prelude. And that's from the evaluation of our own site, ethicsandglobalhealth.org. We've evaluated various domains in pre-post evaluations within the site. I want to highlight 2 of them here. You'll notice in the top, Pre to post, pre-completing our cases versus post, confidence soars, right? Nearly double, clearly statistically significant. Confidence goes through the roof if you take our 10-case introductory ethics curriculum. But look at the bottom. We created a 5-question ethics knowledge test, really hard to create such a thing. Happy to talk about how we should do it. But look, no difference pre to post. So we got these results and we thought, wait a minute, what is it we're trying to do? Confidence has soared and knowledge is unchanged. Have we done more harm than good in creating this ethics curriculum in ways that we didn't fully anticipate? It caused us to ask questions such as, what should we measure? And what would count as a successful outcome of our curriculum? Do we actually want confidence to go down instead of going up? How much should knowledge go up? And so on. So I think it's a cautionary tale that leads into some of these future research needs. So what do I think are the gaps based on where we are at the present? Well, I think it's still true that limited numbers of trainees have informed the existing empirical literature, particularly in light of those many thousands, if not millions, who go abroad. You probably noticed as I went through the cases that most of these evaluations involve self-reported or perceived outcomes, right? They believed it would make a difference. They thought it made them more aware. They believed they were more confident and so on. And there may actually be ambivalence, as I was just describing, about what we should be seeing as outcomes from our ethics education. Is it more or less confidence? What is ethics knowledge? How do we really evaluate ethics outcomes in the short-term global health setting? So that turns me to the last section, which is about the future. Where are we going and what are the 3 challenges that I think we have to address moving forward when it comes to ethics education in short-term global health programs? Challenge number 1 falls directly from what I just described, and that is what counts as success. At present, I think there's little consensus on what would count as success for ethics evaluation. Is it ethics knowledge, like being able to describe the principles, being able to explain ethics concepts like altruism or charity? Is it more attitudinal? Is it behaviors? Is it outcomes, including outcomes of the programs themselves? And are we trying to teach right or wrong in ethics education, or merely, as we saw in one of the programs, a decision process for thinking through how to manage ethics issues? Now, at present, if we want to go the route, which is a really important way to go, of evaluating outcomes of programs, right? We would like to think that ethical programs are more effective at global health and global health equity than unethical programs, right? Seems reasonable to suggest that. But at present, there's actually very little evidence beyond case reports and individual examples that short-term global health programs actually improve longer-term global health. Again, we know there are programs that are highly successful and make a lot of local impact, but as the systematic review pointed out, at that bigger picture level, little evidence that short-term global health contributes to the eventual outcomes of longer-term global health. So this actually reminds me, this debate about what counts as an outcome or what we should be measuring regarding ethics reminds me of a debate from about 10 years ago when there was active debate in ethics and professionalism more generally about whether we should focus on behaviors, what we do, that's the left side of this slide, the left side of the bar, versus the idea of character or who we are. Now, I think this debate about behaviors versus character turns out to be relevant for global health and relevant for how we might think about evaluating short-term global health activities. So in some ways, the classic bioethics approach that I already introduced earlier related to the principles of bioethics, respect, beneficence, and justice, I think reflects a little bit of a behavioral orientation. And we see this in the weight guidelines. We see this in the position paper I contributed to, and so on, where the emphasis here is on what gets done, what benefits are given, how are resources distributed, and so on. If you look closely At the Global Health Ethics for Students paper that I also showed, you actually see a different approach that's more framed, I think, around character. So here the principles are not our classic principles from the Belmont report. Instead, it's introspection, humility, solidarity. And if you look at the questions asked by these principles, they're different. So introspection says, why am I engaging in this global health research or service program versus what am I going to do? And it's that distinction between why and what that I think is a very different approach to how we might think about ethics in global health settings. Now, some of us more recently have written that, in fact, these two approaches are stronger together, that we actually can't interpret even our classic principles of beneficence or respect unless we first step back and have foundational principles around introspection and humility. For example, I can't fully assess the risks and benefits of exceeding my scope of practice abroad unless I'm humble and introspective about what my limitations are and what my role is within a particular program. So in fact, there could be a way to bring these principles together in the future. Challenge number 2 is who decides. I think this is a related question to the first one. It's who decides between these competing conceptions of ethics or of what matters most. And here the literature is, I think, too frequently asked what local priorities are. But there are some interesting findings. Just to throw up a couple citations for you. Here are some papers that actually take the time to ask, well, what do local communities where these short-term programs occur think should be the focus? How should they help inform the way we think about ethics and the way we might evaluate ethics outcomes? I want to show you that a couple examples here where I think that even though the evidence is sparse, there may be a signal that how, which more relates to those issues of character, is just as important as what, those classic behavioral outcomes. So we did interviews in the Dominican Republic, and when we asked interviewees, what do you appreciate most about this particular short-term program? We got responses like this one, the one at the bottom. Because you are friends, you are treating me all of this time I am with you. If you look at these quotes, they don't reflect immediate attention on the what. They don't reflect immediate attention on what is being done. Instead, the emphasis is on how they're being treated. In a survey where we compared what host communities think about what is important from an educational competency perspective versus what is less important, look what rises to the top. Humility, being respectful. Hosts consider these far more important, for example, than being able to conduct or assist in research projects. So I think that we can see here less emphasis on the tangibles, right? More emphasis on the why and the how than the what. But I would always say we have to interpret this cautiously. Remember that historical shadow. Remember the structural inequalities that contribute to this. I would never want to go too far from evaluating tangible impact and looking for longer term contributions to global health equity and sustainability. But I think it's interesting that we see signals of this finding in the literature that align a little bit more with character-based approaches. Challenge 3, whom should we evaluate? This is what I tried to foreshadow early on. This recognized need to evaluate ethics education is complicated, I think, methodologically by those issues of defining what counts as short-term, what counts as global, and what counts as health. There's an absence oftentimes of a clearly defined population in which to evaluate global health ethics education. And there's, of course, a lack of funding also, and the pressure to localize the global, that is, to justify global health activities by their impacts locally on career choices of students, residents, and so on. So I think it's not surprising that evaluations, like I showed you, have tended to be limited to single offices or single programs. I'll give you an example of this challenge. An example that we did where we wanted to evaluate this issue of exceeding the scope of practice. So we conducted a survey of 223 global health individuals. They were diverse. They were students, residents, postdocs, licensed practitioners. We had to recruit them by snowball. Now, some really interesting findings here. Half reported being asked to do something outside their scope, and 2/3 of them did it for any number of reasons. Mismatched expectations, lack of supervision, emergencies, and so on. Trainees, we found, were twice as likely to perform outside their scope. Maybe not surprising, maybe licensed people actually perceive their scope as bigger. We observed the phenomenon for both clinical and non-clinical individuals alike. That is, even people who were in public health felt that they were making decisions or doing analyses beyond their scope of practice. And these qualitative findings suggest the potential for lasting distress after someone has performed outside their scope. Now, really interesting findings here. I think an important contribution, but the reason to present it is, look at our sample, recruited by Snowball, diverse in terms of level of training. It's hard to imagine that this is a representative sample in the way that we might wish for when it comes to rigorous evaluations of global health and global health ethics. So what do I think about measuring impact? A few thoughts that we might discuss as we get towards the Q&A. I think that whatever approach we measure, it has to be developmental and that no one size fits all. We have to remember that if we only choose to partner with or evaluate successful, ideal long-term partnerships, some places and people around the world are going to be left out. And that itself is an issue of justice. I think our approach obviously has to be collaborative, that is decided with and by local communities, as that systematic review of ethics guidelines suggested. I think it should be progressive. And here we draw on human rights concepts of progressive realization, timelines, and benchmarks. We need to expect that our programs actually get better over time and hold them accountable to timelines and benchmarks. And I think it needs to be non-exploitative. We need to avoid ourselves benefiting personally at others' expense. My note here is to be cautious about emphasizing that global health leads to career changes or choices locally. This, to me, and it's only my own personal view, verges a little bit too close towards exploitation, right? Because we're saying the gains locally come at the potential expense of unintended harms and unintended consequences abroad. So those are just a few thoughts for how we might consider measuring impact. Two additional thoughts before I conclude. I do think that medical schools have a critical role to play as leaders and have to recognize the trickle-down effects of their policies, of how they conduct ethics education, how they evaluate it. We see this in the example of the potential unintentional encouragement of pre-med undergrads to do things abroad globally that make their applications stand out. Jess Everett at Child Family Health International has done some great work in trying to shift the way we think about those kinds of applications, looking at them with a little more scrutiny perhaps than simply lauding them as ways that applications stand out. Because if we reward that behavior, we unintentionally encourage it for the future. And I think another major concern that would be interesting to talk about again in the Q&A is the advent of what's been described as predatory global health opportunities within organizations with variable financial efficiencies. Probably all heard about the concept of efficiency within charitable organizations and how they use their resources and so on. This is a concept that needs to be applied to global health organizations as well. So what do I conclude? Well, I think that much work remains. We'd all agree with that. But I think it's reasonable to suggest that we've made progress in both the policy and practice of short-term global health programs over the past 20 years or so. In my own teaching, I've seen attitudinal shifts. I think this shift in thinking from altruism to charity and justice is a really important sign of that progress. I also think, and I hope I've been able to convince you, that evaluation of short-term global health activities, including their ethical aspects in ethical education, is itself at a critical inflection point. I think we need to get beyond self-reported outcomes, you get beyond single site evaluations, and come to agreement about what would count as success when it comes to ethics education in short-term global health. And I personally think that arguably the eventual goal from a global health standpoint is to no longer need short-term global health activities at all. I'll conclude there. Look forward to questions and answers. It looks like we have 15 minutes or so left. This is the link for, I guess you could scan it quickly.